Hello, my name is Jesus Verdeja. I'm the Director of Myeloma at the Sarah Cannon Research Institute in Nashville, Tennessee. And at ASCO this year, I was happy to present on behalf of my colleagues the updated results of the phase 1 Monumental 1 study, the first in-human study of talquetamab, which is a G protein-coupled receptor family C group 5-member D, which is a mouthful for GPRC5D, CD3 bispecific antibody in relapsed refractory multiple myeloma. So this is just a cartoon showing what this is, but this is a bispecific antibody. And this is in a group of those so-called T-cell redirecting therapies. So CAR T cells and bispecific antibodies are T-cell redirecting therapies that basically are bringing your own T cells to go and fight myeloma. In this case, the bispecific antibody has two targets. One target is to GPRC5D, which is a protein found in myeloma cells, and the target is CD3. And so by targeting the myeloma cell, it basically identifies the cell, and then it goes after the T cell, once bound, is activated and goes and kills the myeloma cell that is bound to the antibody. GPRC5D is a new target. It is actually mostly expressed in myeloma cells and very little expression in normal other healthy tissue. And so this is so I'm going to show you the results of the Monumental 1 study, which is an ongoing phase 1 study, dose escalation. And here we're actually going to specifically talk about the patients that are enrolled at what we think is a recommended phase 2 dose. So this is the study. As you can see, it's enrolled quite a few patients, both in IV and subcutaneous, and we found that actually the subcutaneous or by injection actually is easier for patient, and it actually works better. And so this is what was, we looked at several doses, and we found that the 405 micrograms per kilogram dose was the dose that we wanted to take forward in the dose expansion and eventually the phase 2 study. The way this is given is we do a step-up approach. So before we get to the full dose, we give a small dose of 10 and then 60 micrograms per kilogram in the first week. And then we give the first full dose and then subcutaneously, and this is given once a week with the cycles repeating every 3 weeks. So here we see the patients. So in this is just a subcutaneous cohort. And 82 patients have been enrolled, and 30 patients, which is what I'm going to concentrate on, were enrolled at the recommended phase 2 dose. Patients, as you can see, were very heavily, were sort of our standard myeloma patients, with 21% of patients having significant bone marrow involvement, and a third of patients having actually what we call extramedullary plasmacytomas, which are tumors outside of the bone marrow. Patients had a median of 6 prior lines of therapy, and basically had been exposed to all known myeloma therapies, including what we call sort of the big 3 classes of the proteasome inhibitor, the IMiDs, and the anti-CD38 antibodies. This is a safety profile, and basically we didn't see anything that was completely unexpected. So as we've come to expect with some of these therapies, we see a lowering of blood counts, including neutropenia and thrombocytopenia, which is low neutrophils and low platelets. These resolve pretty quickly, though, within a week or so, which is a little bit better than what we see with some of the CAR Ts. We saw cytokine release syndrome in 73% of patients, but really all but one patient had grade 1 or 2, which is a much lower grade or a very manageable grade. One of the things to watch out for this is that GPRC5D is expressed in salivary glands and also in some of the skin cells. And so some patients did experience taste disturbances, as well as some rashes and some nail sort of changes. In terms of the cytokine release syndrome, as you can see, it was very frequent in 73% of the patients, but again, most patients had grade 1 and 2, and only one patient had grade 3. No patient required more than 1 dose of tocilizumab, which may not mean much to you other than that's actually one of the drugs that we use to reverse cytokine release syndrome. And oftentimes with CAR Ts, we have to use multiple doses or either give other drugs to try and sort of reverse the cytokine release syndrome. So here, the cytokine release is very frequent, but it seems to be a lower grade and much easier to manage, at least so far in our experience. This was the overall response. So if you look at the right, you see that at the 30 patients treated at the dose that we're moving forward, 70% of patients responded, with 60% of patients having at least a very good partial remission or better, which is a very deep remission. Obviously, this is early follow-up, so we'll have to see how long these last. But we do have we have quite a few patients actually in the IV cohort where their response rate is actually ongoing up to 22 months. So we're hoping that these are durable responses. And actually here is just sort of kind of the patients sort of listed in this graph here, showing you that the ones with the arrows show that their response continues. And so in conclusion, what we're showing you here is that this new bispecific that targets GPRC5D, which is a new target, actually is very effective. It seems to be well tolerated, and I think, and we're moving it forward. And this is exciting because, as you all know, most of the targets with bispecifics and CAR Ts in myeloma have been with BCMA, which work extremely well. But of course, the concern is that if once you receive a treatment against BCMA, there's a concern that perhaps when the myeloma relapses, that perhaps BCMA is no longer expressed. And so it is going to be very important to have sort of alternate targets. And this is the first of those alternate targets, which is looking quite impressive.